Okay, I mean, it's a sole faculty now. But let's start. What can we do? I have the great company, those who are still here. Uh, this is a case now, the case number 6. So this will be the 7th live case of today. And this is the case of the Sapient Tmvr. Gilbert, Sahil, Anu,
No,
you are
can you
on.
see us?
Yep, we can see
Yes,
and hear
we
very
see
well.
you.
Yes.
Oh, sorry.
Okay. No, we were saying SS. Do you want Amit Huda come down as a faculty there?
Yes.
We can send him down.
Send him over, yes.
Can you get Dr. Huda ji to go down? Yeah,
And ask KM also if he can go.
And even if Parasuram is free, he can go down.
Yeah,
That's good.
What's the number of the?
Yeah, go down with the faculty. Yeah, downstairs.
Where are we going?
Okay,
They're coming.
good.
No,
And you start
let's
now.
wait to see what
Okay, we can show the slide.
Yes.
Yeah.
HP, structural live case HP.
Yep.
So this is a 81-year-old male. Presentation was of NYSA class 3, dyspnea. And if you see the past medical history, the reason for dyspnea is he has had hypertension, hyperlipidemia, but he had a MVR bioprosthetic valve, which was a 29 perimount in 2011. Then he had an Evolute tower that was done in 2020. Was doing okay. This patient has been followed in our structural heart clinic for an obvious reason. But over the last year or so, the symptoms have been getting worse with NYHA class 3 on good medical therapy, which includes ACE inhibitors as well as furosemide and all the other heart failure medications. So today he had moderate pulmonary hypertension when he had a cardiac cath, but nothing on the coronaries. But if you can see here, we can show the echo today.
Yeah.
Stam.
Yes.
So normal LV function and aortic prosthesis is okay. But more important, his mitral prosthesis is the one that we had a gradient of 9 or so, but today with the TE, STAM is going to show.
Yes. Thank you, Dr. Kini. If they can put up the echo.
Just look from.
You tell them to put the echo on the screen.
Echo?
Yeah. So there, okay. Normal LV function, deep gastric. This is the mitral bioprosthetic valve. The posterior leaflet of the prosthesis is flare. The other two have decreased excretion, as you can see. There is MR, which is most likely moderate in severity, coming anteriorly. The mean gradient that we got is 12, pre-gradient of 25. And here, this is the Evolute aortic valve. And you can appreciate the centric anterior-oriented jet from the MR, and you can see much better the flare leaflet of the mitral bioprosthesis. Again, here another view of the same, you can appreciate better. This is a short axis of the TAVI valve, and you can see some mild PVL.
How much you think is MR?
The MR is at least moderate.
Our V waves are very high.
But stenosis, this is the moderate metacardial regurgitation with PA pressure about 75 to 80.
Wow.
This is the transeptal puncture that you can see here. And this is the mitral valve
If you
area.
got the transeptal, you can show it.
3D, 0.9 centimeters square. By pressure half time 1.3 anyway, severe MS with at least moderate mitral regurgitation. And we are across now.
So that was our transeptal we did.
Yes.
I think this
So
case
ideally, when you're doing transeptal, you would go posterior, inferior. But in this case, since we are doing Tmvr, so you go RAO, if you see here.
Can we show the fluoro images?
Flow and echo together, please.
Before you puncture. So you go on fluoro, you see it a little bit anterior, and if you take the valve frame, you put a sapien valve in front of that valve frame. So it's ideal. And then the transeptal needle has to be, you draw a line, which is half of the valve. So it has to be below that. So it meets all the criteria. So exactly that's where we did the burning. And you can show the So you see that after the burning, you just advance gently. And how do we know the transeptal was good? So in the RAO view, you will already see that the transeptal sheath is right in front of that perimount valve. So we're given heparin, ACT is above 300 or so. Now we will do our other steps. Any questions so far?
Now, just keep going.
So you want
So
to
the
discuss some
stepwise-
CT images, some slides?
Yeah, do we have any slides? Okay, we can look at some slides, please. I'll go over them
Yes.
while they. So this is a very interesting case, actually. If you can show the slides for the audience, please. So we already talked about the comorbidities, already seen the echo. But what we actually initially, when the patient screened for valve-in-valve Tmvr, we'll show you in a moment. I'll just keep advancing. So you have the Vini Baplatz app. So this is a 29 paramount. You can see that here. And so that the appropriate valve would be a 29 sapien free. We actually typically post-dilate to optimize the valve frame expansion. Then now some people even consider valve fracture to actually consider to avoid the valve being underexpanded. But if you look at this interesting case, that you see this is the CT scan. And look at neo-LVOT because as Vinny's talked before, it's all about the neo-LVOT. And it's very small, 105.6 millimeters square. The recommended neo-LVOT for valve-in-valve is 200, so or maybe 180. So this is not even close. So actually what we end up doing, and you saw there was a big septal bulge on the left side, bottom left of the screen. So we actually went ahead and did a septal ablation. You can see that here. We ablated the septum. We did and you saw how we did the alcohol septal ablation earlier in the other live case. And then we wait about 6 weeks. And look at this. The neo-LVOT actually improved significantly. And you can see that we actually managed to successfully shave off chemically the proximal part of the septum right below the evolute. And so we now feel that we have a clear pathway to allow us to safely implant a sapien-free in this valve-in-valve Tmvr. So I think we now, you can have Dr. Kini and Sahil proceed to explain the case.
Why?
Yeah, so let's take this out.
Any questions or comments
So
from the
far,
panel or audio?
If any question from the audience, please post it and we'll convey it there. Because last time,
Multipurpose.
So we
could
have
get-
Agilis already in there. You can see that.
Multipurpose.
So before we did the transeptal, the Edward sheath is already in the groin with the E facing up.
Safi.
And now what we'll do is we will take a multipurpose and we think a J wire, we should be able to cross this mitral valve with just a J wire.
I think that's a good point. The significant mitral regurgitation, we should be able to cross. If not, we'll use a
Did you clean
straight
that?
stiff. Yeah.
Yeah, I think one thing important to point out, and Stam and already did with Lucy at the back, the imager, is that every prosthetic valve dysfunction is different. You can have pure MR, you can have pure MS or mix, and this one is clearly a mix, and you can see that flail thickened bovine pericardial leaflet just causing both stenosis and regurgitation.
The sheet back first.
So maybe you
Go
can
with the multipurpose.
emphasize, is there any difference in terms of the transeptal puncture? And maybe our panelists can answer that in terms of when we do for the TR versus for TMVR?
Yeah, I think you want to be inferior and posterior for this procedure. And I think you did it already very nicely. You showed the RAO projection that you have a straight shot. The important thing is not to be too superior.
Okay.
Okay, fluoro save, guys, you see how we crossed?
Yeah, almost there. Almost
We're
there.
I know. So
Yeah, I think that's a very good point, Dr. Sharma. This is a very
300,
fluoro-guided
300.
transeptal. Yeah. Deliver all the way.
yeah, out. Come back
Okay.
and out. We
Now
go
get
the
me a
pigtail.
pigtail.
So you can already predict that this will be a very nice trajectory. Look at how the agilis and the wire goes into the LV apex. On the RO projection, you can see the valve itself is already in a parallax-free projection for our implant view. So that's very important. If you see your agilis have to buckle upward, then down to cross into the valve, that's a bad sign. That means you probably puncture too superiorly, and then you're going to may potentially struggle getting a rail to trap the sapien-free valve across the septum to the prosthesis. So that's a very important teaching point, and we kind of learned that earlier when this procedure got started, several years ago now. And you can see echo images very nicely. They're showing you that you cross and where you cross.
Yeah.
So that's very important. And also, Stan and Lucy can be comment on the 3D MPR, how that helps as well.
Yeah, actually, with MPR, we know exactly where you have to go to cross over. And because that was the only opening anteriorly.
So
on
this
the
is a long
prosthesis.
pigtail. You see that? We are in the LV now.
Yeah.
And on this long pigtail, we will go with the stiff safari wire. Then we will take out our Agilis catheter
Yeah. ACT is good.
We're going to balloon and take out
and
the edges.
pre-dilate the septum.
Both.
Careful here. Yeah, everything can fly out.
You good? Yep.
So another teaching point here is that the
ready?
curve has to be facing down. So you see that? This is kind of what we do for Tmvr, for native Tmvr. Some of the technologies like Sophia, for example, has a stiff wire, and M3 and others, but you need to have that stiff wire, the curve facing down, the opposite of TAVR, which is facing up. That allows you to have a proper trajectory and inflation when you deploy the valve. Otherwise, you end up potentially causing asymmetric in terms of deployment and potentially risk migration.
Careful, careful.
Yeah. So any questions about the trajectory here?
Yeah.
Dr. Sharma, team?
No, all looking good?
So we're going to balloon the septum and balloon the valve now. And then we're going to go with our
Did you find Amit in
sapien.
Parasuram?
Yeah, they all are here.
Perfect.
All right, guys.
Any
come to
thoughts
the
from
seat.
Amit or
Yeah.
Parasuram KM?
Yep, they're all going to join us now. And they tell us about the balloon you are going to use for the septal dilatation. Size-wise and what
Yeah,
is
so
the
it's
protocol?
Right, right. So 14 should usually work for most of your 29s. Anything
14
20,
and 20.
Yeah.
Or 40.
14, 40, yeah.
14,
And then
40. Okay, so we're going to do the septum, and then we also, what we like to do is use the same deflated balloon and see if the balloon will get into the mitral valve. We'll dilate the mitral valve. That gives us an idea how the sapien will behave.
And any
We're
opinion,
going-
any
oh,
if you
good.
advice
Ready?
to them and your opinion, the way
the
you
wire?
do a little differently, so just comment on, please.
No, we do the same. I think
You
it's
can-
very important that you adequately dilate the septum so that you don't have to fight it.
you can see the waist there.
Yeah.
Yeah. And keep the balloon inflated for maybe a minute, minimize the recoil, and don't spend too long waiting until you bring the sapien. But it's beautiful
That's true.
technique.
So one thing we've seen, Neil, is that sometimes when you do that, you cause a vagal response. The patient blood pressure may actually drop, and you're wondering what happened, but that was because the septum being pressurized by the balloon. So
Okay, good.
So it's a good expansion. We saw the waist. And I was saying 14 for most 29s, 12 balloons for most of your 26, 23s.
Yes, to 3D.
So this is a good sign that the sapien will
Sinai.
move well. Okay, good.
Yes.
Okay, we have the valve ready.
Valve ready? Laura? Go ahead.
Come out. Careful.
okay, I'll back out once you're done.
Yes.
Yeah.
You got wire? Okay, you got wire. So I'm gonna back out now. Why? Because you need to see the E sheet being brought back so that you can mount the valve. Remember, this is a commander system, so you do need to load the valve onto the balloon before you can cross the septum to the mitral prosthesis.
And same thing, you see that the skirt is facing different.
Yeah. So skirt is antegrade. Okay. So that's or atrial, and
Yeah.
E has to face down, right? Because this TAVR you face up because it goes one way, and now the E has to face up down to go the opposite way.
Skirt is good.
Good, you're good.
Floral, please.
Yeah. Go.
And I'll bring it down so they can see it.
Wait.
No, I want to see the sheet. Okay. So the key is to maintain that rail, not to buckle, not to have slack. And so that's very important to visualize that.
Stay here. Pull the sheet back.
I'm
Okay.
pulling the sheet back.
You can go a little more if you want. Yeah,
You're
good.
good. You're good.
Wait. Let me get the sheet back a
Good.
little.
Okay, good. So now we're mounting the balloon, right?
Wait, wire?
Yeah.
Don't worry.
Wire's good. So I'm basically putting a little forward tension on the wire to maintain that rail and the tracking.
Looks
So
pretty good.
now it's
here.
good. Yep. So we're ready to cross.
Flex.
Yeah, go ahead. Go ahead.
Yep. So I'm pulling the wire a little bit just to help with the railing, so you can see it track very nicely. Perfect. Okay.
Flex.
So now I'm going to mac in to get the angle.
The key is not to
Okay,
let
let's
it go
center this.
into the ventricle because then it can get stuck.
Yes.
Yep. Yep, that's right. So
Yeah.
we also learned to start a little bit more atrial. So if you too ventricular, it's harder to bring back. It's easier to push forward, then I think we need to go a little more atrial.
Atrial, pulling back.
I think
I can stand up for you, but also we need to test. We need to test pace.
Okay, 180.
Oh,
Sinai.
good. That's better.
Sinai.
Sinai.
Off.
Good. I think this is good.
You like it?
We start here, go
Yeah.
very slow.
Yeah.
Yep.
And make micro adjustments
Yeah.
as needed.
Okay. We went deep again. Just be
Yeah.
careful.
Yeah.
Good.
Okay.
Long pacing run.
180. We are going up. Go.
Good.
Go.
Good.
Full.
Fantastic. Good.
Full.
Perfect.
There's no rush. Take your time.
Yeah.
No. Please.
Yeah.
Okay. Down.
Floral, please.
When we are
Floral,
half
please.
through, you have to immediately.
Okay.
come back.
Off.
Off. I'll be your post.
I want to do one more inflation. Perfect.
Okay. Ready?
Good. Okay.
We're gonna post dilating again.
Yeah.
Ready?
Do you want to
Focus.
put one more CC?
No, we're
Okay.
good. We're good.
What's the point?
Pace 180.
Here you go.
Will you also do a 2 inflation?
Yeah, often. It's good to flare the ventricular side.
Good. Got it.
Yeah.
Everything.
Yeah. Sinai.
Yeah, everything.
You're a little bit low, yeah.
No.
Okay.
The ventricle. Yeah, no, I know, but.
Sam, look at the floral.
The balloon.
Yeah,
Yeah, balloons.
off.
Okay.
Yeah.
Off.
Off.
Okay.
Okay. Let's get a pigtail, please.
All right.
So this is unlike a TAVR. This is retrograde, right? In terms of the valve, you have to put an exchange for a pigtail so that the wire doesn't get snare against the leaflets. So it's very important.
Swap.
I think we got a perfect landing here.
Yeah.
We have good flaring on both sides.
80-20, yeah.
Yeah.
Any
But-
thoughts, Neil,
better,
or
yeah.
SS,
Yeah.
or KM?
Good.
Yeah, you're happy you did the alcohol septoablation.
Yeah.
Yeah.
Do you double inflate all
Yeah,
the TMVRs?
We do here at Sinai. I think Neil says probably there's always a little bit of recoil against a rigid surgical frame. So that's at least from our experience that it helps. You can add volume. You can leave the one the same, but I think it's not a bad idea. And I mean that we talk about optimizing the frame expansion.
Well, we can discuss valve fracture. I guess you would not do it in this case, given the borderline LVOT, but in other valves, would you routinely fracture, Gilbert?
Aortic, yes. Mitral, we have not. I mean, I know some people have done it, but it's not that easy to find a large enough balloon, a non-compliant balloon to fracture. I think the smaller mitral valves, like 25, 27, you probably were fracturing. I agree with you. And I think there's some early data from Vini Bapat's group showing the Hall and under expansion. But, there's still a potential risk of AV groove injury, and that's can be catastrophic. So.
I mean, the downsides that we've seen of mitral valve and valve is a gradient, right? So I think routine fracture in smaller valves is, well, there's not large published series, but the ones that are out there show that it is safe, and that's really been our experience.
Right.
6.
Yes.
Good.
EDP is around 10. Yeah, very good.
Okay. Good.
All right.
What does the echo team?
Yes, yeah, perfect. No MR. The gradient is down to 5. Perfectly working valve.
Wow.
We
All right.
saw it again. We saw it before. Yeah, no MR.
Done in
nothing.
time.
No PVL. No MR.
Yeah, perfect time.
On time.
And
Beautiful.
that's it. That's it. You can see it there. Yeah.
Now the
All right.
anticoagulation.
Check some LA pressures.
Let's discuss about the anticoagulation for this
So
patient.
get the deep gastric-
Everybody routinely
the gastric
anticoagulate,
together.
right?
Yeah.
3 months.
Yeah, DOAC.
Yeah. Yes.
Let's zero, please.
And what is the threshold for the ASD closure?
That's what I think what we'll do is we are going to get the pigtail back
Those are
and
the
then
velocity. Yeah.
Stan is going to tell us.
Yeah, I'm seeing the LVOT gradient just to prove that there is nothing. Let's take the velocity.
So V waves have come down from almost 60 to 42.
Wire?
And
35 wire.
we don't usually routinely do ASD closures. It's a small bore procedure. Most of these heal. World over, the rate is around 2 to 3% of ASD closure. Most of them are bidirectional shunts with hypoxemia. And if you have severe TR or RV dysfunction, then it makes sense. But in these patients, I feel there's so much compliance issues. The ASD actually sometimes helps as a pop-off valve also.
Yes. Sorry. Yeah.
Okay, now
Let's measure the.
show the ASD. I mean,
Yeah, ASD.
pull it back.
Some color.
Yeah, we unless it's bidirectional, we don't
Yeah.
usually close it
It's,
acutely. We usually
left or
wait
right.
30 days.
Left
So,
or right?
Yeah.
It's how much it measures? It's measured loose. And yeah, 30.
That's fine.
It's tiny.
We'll wait for 30 days.
The problem is that, because the PA pressure was high, so.
Yeah, it's okay, Stam. Let's
Yeah.
see how the patient does. Most of them
Of
close.
course. That's the.
Okay, if
Very good.
everybody agrees.
All right.
Questions, we are.
That's it for the live cases.
All right, fantastic.
Thank you.
Great.
Thank you.
Okay.